Good evening, colleagues. You may wonder why I'm holding a microphone and you can't actually hear anything apart from my voice directly. I'm told it's for the online audience, right? That I have to hold it by my chin. So anyway, my name is Ibrahim Abubakar. I am the Dean of the UCL Faculty of Population Health Sciences and a Professor of Infectious Disease Epidemiology here at UCL. Inaugurals are a very special moment in our academic life and career. Often we are too distracted, whether searching for a grant or marking scripts or trying to support our students, undergraduate and postgraduate. Only once in a while do we get to stop and reflect, celebrate, and feel very proud of the remarkable impacts and the journeys that we take and enjoy every moment, not just the achievements, but actually the process of getting there. Celebrating colleagues is therefore something that I find really, really dear to my heart, and I wish that we do that even more often, i.e. at all levels of our careers. But achieving a chair is one of such special moments where we should all stop and celebrate. But it's particularly special for me because today we're here to celebrate the inaugural lecture of Professor Kabir Sheikh, who's not only a long-standing colleague and collaborator in my own research, in addition to my administrative role of being dean of a very large faculty. Kabir is actually a collaborator and long-standing friend on a range of projects and research that we've done. So it makes it ever more special than the introduction of yet another colleague. I remember meeting a much younger Dr. Kabir Sheikh with a lot less gray hair, yes. It's almost a decade ago now, and it doesn't feel that long, but it is. But it was clear to me from that moment that his confident, understated contributions, his articulate and very clear thinking, his intellect in that health system space was of the sort of force and clarity that I knew he was going to not just arrive at this sort of position, but shape global health policy around health systems. I was therefore not the least surprised that his career and path has taken him through this journey. At that point, he was leading global health and health systems at the Public Health Foundation of India. And for those who don't know, the Public Health Foundation of India is this amazing entity set up by Indians within India that sort of has transformed public health in ways that I think every middle-income and low-income country should emulate. Indians leading the thinking so that public health, epidemiology, health systems, and related research has embedded into the running of and thinking of policymakers within India and ultimately internationally. So it's remarkable that within a decade of leaving medical school, Kabir has found himself in a leadership position within this remarkable organization and shaping policy within the country, but also internationally. And consequently, not surprising that not long after that, he was attracted to the international space, initially through multiple honorary engagements in Australia, across Asia, and indeed here in the UK, and then successfully secured multiple grants, produced outputs, books, publications that shaped and informed policy in many, many countries, but importantly, within India itself. So as a consequence, when I was asked by Richard Houghton to lead the UCL Lancet Commission on Migration and Health, and I was looking for a partner who could lead the health system work, of course I turned to Kabir. And Kabir assembled a fantastic working group within that commission, including Shreya Bimbola and others, then a much younger Shreya Bimbola, who's now editor of BMJ Global Health, as well as multiple others, including some in this room I see, actually. So good to see, I was going to say old friends, young friends in this room that are here to support Kabir. He produced the analysis and content of that report, and ultimately, when we published the UCL Lancet Commission on Migration and Health, our main recommendation and the thrust of that work ended up being on the health systems work that Kabir led. So a lot of the subsequent impact at the global level and at the regional level that we achieved on policy were actually as a consequence of the remarkable work and analysis they did around healthcare access, which was our main contributions. And so when the report was launched in Marrakesh with the launch of the Global Compact of Migration, that was our major theme. And I'm incredibly pleased and proud about the subsequent impact and influence that report has had in the migration and health space, i.e. putting health systems in the center of this. Another dimension of Kabir's work, because of that intellect and because of his ability to critique health policy and health systems, is the fact that he gets invited to contribute to policy groups, multiple policy groups. And the first time I interacted with Kabir on a policy group was on the MRC's Global Health Group, which is now morphed into an Applied Global Health Board. But at that stage, it was an advisory body that occasionally had some oversight on grants. And I remember distinctly that whenever there is a health system proposal, everyone was waiting to see sort of what angle and what critique Kabir had. And it was clear that although there were older, more established health systems researchers on the committee, everybody valued that input. Therefore, not surprisingly, multiple organizations and bodies, Wellcome Trusts, other global funding agencies have all invited Kabir to sit on their board. And I'm delighted that shortly upon his appointment here at UCL, NIHR asked him to chair the Health Systems Board, which is an amazing opportunity to influence, again, future research and the next generation of researchers. I'm also pleased and proud because I'm aware within the health system place, through the creation of Health Systems Global and other global initiatives, Kabir has had an outsized influence on the training and the future of a whole range of health system researchers that are based in multiple countries. I mentioned Shay as just one example, but there are many, many others whose careers have been hugely influenced and benefited from your contributions. I believe that, Kabir, and I'm looking forward to this fantastic lecture to hear a summary of that journey, but I believe that we are incredibly lucky at UCL to have you, and I know that the field of health system research and global health is a lot better off because you've chosen to dedicate your career focusing on lower middle income countries, at the people at the highest need of innovation, thinking in global business, in health systems, and therefore the Global Business School for Health and UCL more widely are delighted that you chose to come to us after leading the work on health systems research and academic input at the World Health Organization. This is the right place to stop and do some critical thinking to help us educate the next generation of health system researchers, and I'm looking forward to the amazing work that you're going to do subsequently. I'd like now to formally introduce Professor Kabir Sheikh. I'm looking forward to the lecture.
Thank you, Ibrahim. I don't have a mic either, but I guess you can hear me. But if you can't, then just let me know, and I'll speak into a mic. I feel quite humbled by that. Sorry, a little bit emotional, actually. I got the claps before the lecture, but I hope that you will also clap after the lecture, maybe just one or two, yeah? Don't feel obliged. But no, I have my thanks at the end of my presentation, but I do also want to start by saying a quick thanks to Ibrahim, as well as to Professor Nora Colton, for the fantastically warm welcome that I've got at UCL. And I'm told that that this is, normally it takes like 2 years for an inaugural to be organized, but this is my inaugural after like a couple of months, and I hope to do justice to this role. And I hope to also say a little bit more about this topic today, the changing dynamics of mixed health systems in LMICs, and really delighted to see many of you here who've been sort of fellow colleagues on this journey with me, and I'll actually be signaling to the work I've done with many of you in the past, but let me get on with it without further ado, and I will identify some of those links. So as I said, it's not been a straight and narrow road. I mean, I think if somebody asked me how do you become involved in health systems research, health policy and systems research, there was certainly no bachelor's in health systems, but not even a master's when I was early in my career. So it came about this way. And these are just the institutions that I've been most formally associated with through my career, starting with medical school in Delhi University, then with a small NGO in Western India, the Center for Health Research and Development, the London School of Hygiene, where I did my PhD, and have been associated with a number of fantastic colleagues for a long time. And then I think the kind of longest stretch of my career was at the Public Health Foundation of India, which Ibrahim signaled, and that was in some ways the most significant and formative phase of my career, and I will be touching on many of the research projects I did then. And then that took me to the Alliance, and why there's and then finally UCL. And why sort of these are all open-ended is because I feel like my association with all of these has not really ended. These were all beginnings, which will continue. And in many capacities, I am also still associated in an honorary role, but still I feel that these are the things that have contributed to my journey, the influences, and they don't really stop at any given point in time. And the other sort of bridge, the other types of bridges, I always find myself stuck between two constituencies in different ways, and sort of finding myself being the interlocutor between those constituencies. And one of those is my experience in India, and as Ibrahim mentioned, the Indian experience has been very central to my understanding of the broader world. And I think that sort of the depth of that experience was important then to try and to create that depth was important to then try and understand the breadth of what goes on in other comparable settings in the world. So I will be speaking a little bit to that and to that journey. And then the other big kind of, let's say, paradox or dilemma that we find ourselves in as people who do research on subjects is that we often find ourselves thinking, oh, is this actually really contributing to change? Are we just writing things that go and sit on shelves? Or is it actually going to bring about something different about the subjects we're researching in the real world? So that sort of contest between doing research and making it actually matter where it's supposed to matter has been another kind of bridge that I've tried to cross and construct over the years. And then the final sort of bridge, I thought about it a little bit, and I thought like 2 bridges is too few. I should actually have 3 bridges. So I thought, what is the third bridge that I've been trying to cross? And I think that's where it comes to this particular moment in time for us as people who are interested in health systems. And people, everybody says the 2 years that we lost due to the pandemic, that was kind of like a void. And people say, what a post-pandemic health systems, is it different? But I think the whole world really thought that. It wasn't just about health systems, that has the world changed and is it different? And I think what it did is gave some of us pause and time to reflect a little bit about what has gone on in the past and really what that means. Like, is this a reset? And then is the future going to be completely different? Are there things that are going to be qualitatively different, or are there things that we will need to continue to draw on from the past and to understand the future better? And that's been a theme of some of my work as well, as specifically on learning health systems, and I'm going to speak about that a bit as well. And that's, again, comes back to the theme of the lecture, is I'm going to talk a little bit about not just what I've done in the past, but also what I believe to be important threads around the future of health policy and systems research. Okay, so those are some more bridges along the way. And each of those have been absolutely as important as the primary institutions where I was based. So a long-term association with the Ministry of Health in India, starting off in my work in a government medical school, but also right through to very important initiatives that were taken by the Ministry of Health in India to capture and envision health systems as an Indian enterprise and as an intellectual enterprise that was driven by Indians, and the Public Health Foundation of India very much a part of that initiative. They're color-coded very broadly as policy, academic, and research institutes and influences, but I think many of these institutions themselves are what I would call boundary-spanning institutions, that they spoke between policy and research, they spoke between academia and research. WHO has been a long-standing connection. I worked with the Different Resource Center a long time ago in New Delhi. And then the research influences over time, I've listed some of them: a long-term association with Health Policy and Planning, the journal, based on the London School, and then this coming together of this fantastic community of people who are involved in health policy and systems research, which came together as Health Systems Global, which was the first ever membership society for health policy and systems research. So I'll speak to some of these as I'm progressing, but just to illustrate that it's been a journey together with all of you. Another formative influence, the London School, and John Porter is here, who was my PhD supervisor, but who's been my most consistent supporter and friend for these last 20 years. So again, I must indicate that as well. Okay, so this is the main substance of the presentation. And these are the 4 things I'm going to talk about, and I'm going to take quite a bit of your time this evening, but hopefully not too much so that we can't have a nice drink at the end. I'm going to talk a bit about the health systems ontology, sort of how we frame health systems and what has been my engagement with understanding what health systems are, and talk a bit about a few frameworks and some research that we did which helps kind of expand that vision and understanding of what health systems are. And again, very much a continuing conversation. And then the depth of my work at the Public Health Foundation of India primarily, which was focused on health systems governance. So I'm going to talk a little bit about governance and some of those projects. And I see Nell Roos is here, and she was our partner for many of those projects and supported us for that work. And then this part on making research matter, and what were the kind of institutions that I was involved in and the different structures that I was involved with, which actually supported the world of health systems research and buttressed it and helped build capacity, helped build the kind of institutional frameworks that actually allowed health systems research to be conducted and to be promoted and advocated, and what that means. And then just a couple of slides at the end which talk a little bit about change in the future and drawing really on the past. Okay, so the first one, seeing health systems as social systems. So quite early in my career, I was exposed to this idea of health systems, and that was when I was probably as a physician in an intern in a government hospital in Delhi. And primary healthcare was one of the buzzwords we used to hear a lot at that time. Alma Ata was still very much in vogue. That's the original declaration of primary healthcare, which was in the 1970s, but still in the 1990s when I was going through medicine, it became it was a sort of a framework for how we would think about health systems. And then later in my career, universal health coverage became the buzzword, sort of somewhere through the 2000s and 2010s. And now to compare these two, so what is the kind of real torchlight? What's the beacon? What's the values that are driving us? What are the goals that are driving us when we think about strengthening health systems? And for me, the distinction between the two was that primary healthcare spoke very specifically to some processes and phenomena that are social phenomena that needed to get addressed. So I mean, specifically, the Alma Ata Declaration was very quite pointed about addressing medical elitism, for example. And it was also spoke about involving citizens in health planning, right? So these are actually not really macro level themes. They're actually quite specific institutional, social concerns that arose from the experience of the people writing those documents, and were not just theoretical. They were not in abstraction. So that really struck a chord for many of us in India. And it's not a coincidence that a lot of the precepts of Alma Ata really came from the experience of some of those actors from their work in India in tuberculosis control in the 50s and so forth. So this sort of dual character of the Alma Ata Declaration, the sort of part science and part politics, and very radical politics, was really compelling and really interesting at that point in time and drew one into that subject. And then when universal health coverage came, it was much more of a science of health systems. It became like, this is the framework we need to look at in order to progress health systems. This spells out the goals very clearly. And it took health systems beyond just healthcare towards a much broader ambit. And this is a quote from, so these are two articles I wrote in different, actually quite similar points in time around the time. This was just before I joined WHO, and I wrote an article for the DG, and the DG actually tweeted it and said thank you. But I don't think I ever got a chance to actually discuss it with him when I was there. But this is one of the things I said, that universal health coverage at that time, there was a big focus on health security, and there was a pandemic at that time as well, a major epidemic certainly. And then that's when everybody remembers health systems, right? Everybody's like, oh, we forget about health systems in between pandemics, and when there's a pandemic, we're like, oh, we forgot to strengthen the health systems. So there was a lot of the buzzword, a lot of buzz around health systems. But I thought it was, that being driven quite strongly by this sort of threat and fear rhetoric. And I made this point that we need to focus on the care and not only on the fear. And I think that's what universal health coverage has. It has, it talks more about the goals. It's very scientific, but it does have it does leave it open to different interpretations, let's say. And it isn't so specific as primary healthcare was. But still, these were the two kind of main lights that really guided us all these years in our work on health systems. And then these are the sorts of frameworks that started coming out from the good and the great, the WHOs and the World Banks and the Harvards. And these are extremely good frameworks. I'm not going to knock them over here because they actually, I mean, the building blocks framework is still extremely relevant. It's like in one single image, it tells you exactly what a health system is and what are the components and how you can plan and how you can act on a health system. And the control knobs framework, which is the second one, is also actually quite a good framework. It's more explanatory than the building blocks framework. It tells you what you need to do in order to bring about change in a health system. So these were extremely useful, and I've used them multiple times, but they were still somehow insufficient to describe what I saw and what I experienced health systems to be. And that's from my experience both as a citizen of a lower and middle income country, trying to access care, trying to provide care as a practitioner. I got involved in the Public Health Foundation of India at that time, so I was also involved in planning and researching. So this does not look like the health system that I see when I go out into the villages and the cities, and so it's not enough. We need more, right? And that's when, through the time I finished my PhD in 2008, and I started working with a range of global actors who are also interested in the sort of community started coming together of people interested in health systems. We moved from this, we wrote the series of papers which really helped move some of the thinking from this sort of very functional understanding of health systems to this much more, some would say, messy understanding of health systems, which highlighted two or three things. It highlighted the software of health systems, so the kind of all the intangible elements, the power, the affinities, the culture, the ideas, interests, values, all of those things as being equally important as drivers of health systems. Also the fact that decisions aren't just made at the top and get implemented, right? Decisions are made throughout the system. So that's another very important thing we articulated. And it's not the first time these things were articulated, but I think that it was one of the first times they were brought together in a series of articles, which then became quite influential in shaping the field. I wish some of those people were here, but Tara Hansen, Lucy Gilson, Irina Japong, these are the people who we wrote these articles together with Sarah Bennett. And the third thing I think that this framework does is it identifies that health systems problems are, as well as the solutions, reflect societal issues, right? So what we see as problems in health systems are not just problems in the sense of problems in a machine. They're actually social, and I actually prefer the word societal problems because they actually reflect specific phenomena that occur in society which find reflection in how health systems operate. And I'm going to illustrate that through some of the examples I'm going to give later on. And then there's also this typology we came up with, the difference between macro questions, meso-level questions, and micro questions. And this is going to become significant later. But macro questions concern themselves with architecture and oversight. Meso questions are more about organizational functioning and interventions. And micro questions are about the individual. Not a perfect typology, but one that had its uses. And then, so sort of moving on from this sort of social construction of health systems came a further set of readings that I can see Maureen smiling in the front, and she is one of the leaders in the thinking of this understanding of mixed health systems. Sanya Nishtar, Maureen McIntosh, these are the references that I started reading, and I said, oh, this is much more, kind of accurate in my understanding of what I see. And so it's like mixed health systems in low and middle income countries entail centrally planned government health services that operate side by side with private markets. There's one definition, I think it's from Oxfam. But then these three criteria that I think Nishtar identified in one of her papers, she later became the health minister of Pakistan, for those of you who don't know. Diversity in healthcare provision, dominant poorly organized markets, and compromised public services. So what we see is there's a formal part of the health system that we are attuned to thinking about when we plan and when we organize and we make policies. And then there are all these different parts which we often neglect, right? We think those are sort of outside of the mainstream. But that's not what citizens think. Citizens are actually using these services and accessing these different facilities and doctors. There's traditional providers. There's a whole range of informal providers, right from home-based providers through to drug shops, through to a number of other semi-qualified or qualified providers. There are community health workers. who always straddle this boundary of whether they are volunteers or employees. That's a big tension for community health workers. And then there's a massive private sector, which exerts itself in many different ways, both in the financing of health as well as in the provision of healthcare. And then this tweet just yesterday from Awad Mataria, who is Health Systems Director at the Eastern Mediterranean region of the World Health Organization. So we are still, and he's a very smart guy, so he's saying, they've done this paper on classification of the private health sector. We still don't have a proper classification of the private health sector, and this is, and WHO is doing some work in this area, but I would venture that there are some systematic reasons for this, our neglect of all of that happens beyond what we consider to be the formal and typically the public health sector. And so he's saying having a functional taxonomy is key to facilitating effective engagement in advancing health and well-being, and this was exactly our impetus when a few authors and I developed this taxonomy. Sorry, not a taxonomy, probably a typology in the sense of how sociologists use the word, because it doesn't reflect a mathematical kind of reality, more like a social pattern that we see emerging. So this was an attempt of some of us, so the authors were from Cambodia and Iran and Bangladesh and myself and a couple of other authors as well. We wrote this piece on Asian health systems, which is mentioned over here, but also finds resonance in some of these other publications. We did a special issue of Social Science and Medicine on Health Systems of Asia. So this sort of tries to typologize, well, really it was on the workforce primarily, but I think it can be extended to service provision more broadly. There's a formal, the informal, the specialized to the lay. Some of those categories that I mentioned, the home providers, the care providers, come very much on this side of the spectrum. The public to the private. The allopathic, there's a terminology, allopathic and non-allopathic, which is not universal, I realize, but it is used sometimes to indicate the distinction between formal biomedical sciences and other forms of traditional systems of knowledge. And what's specific about this, there are a couple of things that are specific about this framework. And this is the first thing. The first thing is that physically, culturally, these sets of providers are often closer to the people who need care the most in low and middle income countries. Not like it's not universal truth, but there is a lot to support this hypothesis. And on the other hand, you see most of the policies being oriented towards, and most of the discourse being oriented towards the left of the spectrum. The other thing about this framework, two things. The first is that these are continuums. They are not binaries. So what we often see in lightly regulated systems is that there is not a very clear distinction between the private and the public. There's a lot of bleed. There's a lot of private behavior in the public system. There are a lot of public-private partnerships, some more formal than others. We also see a lot of mixing between knowledge systems, and there's no clear distinction between traditional providers and allopathic medical providers. And so these are more like spectrums of behavior and spectrums of rather than categories, rather than discrete categories. And then that complexifies and complicates a lot of the conventional wisdom around the public-private split in provisioning and financing. And that's the basic fundamental argument on which we have based a lot of our health policies, our global health understanding of health systems, is that there is a split between the public and private in the provisioning as well as in the financing. And I'm going to touch on that. It creates specific problems for governance, specific challenges for governance. So we're going to address some of those. And that's when a lot of us were thinking on similar lines, and this amazing group of people got together and decided to set up this program at the Public Health Foundation of India called the Health Governance Hub, where we said we really want to start thinking about some of these issues of the mixed health system and heterogeneity in the private sector, in the health sector, and try and understand how decisions get made within the health system. So try and peek into this black box of what happens in the health system. But do it specifically from a kind of what we call an emic perspective. Maybe we didn't even use the terminology then, but I think in retrospect we did use that a lot. They want to get into the heads of people who are working in health systems and try and understand how they experience it and how they make their decisions. So, and then we set up a fairly big program which worked for about 8 years before things changed and as many of us moved on. And this is a slide that sort of captures some of that work that we did at the Public Health Foundation of India. And we focused a lot on some of those sets of those people in the health system who are not really seen as having a voice or seen as being part of the mainstream. Again, I don't think we did it very consciously, but we were aware that there are power differentials within health systems. I think the other thing about that framework is that all of those spectrums, all of those axes of heterogeneity reflect domains of power and politics and contestation. And I think that's something that we also wanted to unpack and get into. So we did this bit of work on rural doctors, which I'll speak to a bit more in detail on the next slide. Guideline implementation by private practitioners. Private practitioners are able to resist public health norms. This was actually my PhD research that I did with John. They're able to resist the imposition of guidelines, but on the other hand, they don't find themselves able to contribute to broader discourse and policy and learning. So they're actually what we wrote this paper called Disempowered Doctors. We said, okay, they have certain types of negative power, but they don't have positive power to contribute usefully to public health thinking, to policy. Integrating traditional providers, TCAM providers for short, often the subject of assimilative policies that treat them as lesser physicians rather than as something different, and some people who can contribute something unique and different. And again, why TCAM providers are very important, say in a context like India, is because India trains large numbers of them in very formal settings and produces almost as many formally trained TCAM providers as it produces regular providers of biomedicine. I'm sure it's similar in China and in many other settings. And then this work on the nursing profession, and something that I think won't surprise anybody, but we did the research and actually found it out, so we managed to write it down. Professional hierarchies have a significant impact on nurse leadership and impede the performance of the nursing profession as a whole. And we'll again come to that a little bit more in detail. And then this is one of those papers, one of those projects on the rural doctors. So this was one of my first projects, and I'm quite kind of one of the pieces of work that I'm quite proud of, because I think one of the things I like is how we came up across the research question. So this was a research project part of a broader research project that addressed this issue of workforce adequacy. Right? We don't get enough doctors to work in the villages, and villages are underserved. So that's the conventional wisdom is, either we say, the first thinking is how can we make doctors stay on, right? We want professional people to go to the villages and stay on in villages. And so there was a bunch of studies done on this question. And then this was all done in collaboration with the Ministry of Health. So very close policy linkages, responding to specific questions that policymakers had. And the second question that comes is, okay, if we can't get doctors to go to the villages, can we replace them with some other type of providers? And then if we can replace them, can those other types of providers provide quality services? And these were questions we were asking in 2009, but we are still asking them today, right? They're not solved questions. They're really, I don't want to loosely use the word wicked problems, but it is one of those really problems which have not found a clear solution. But then on the other hand, you can also look at this question. So, what are the factors that prevent doctors from staying on? And then we were like, okay, but what about the doctors who do stay on? Why do they stay on? So let's go and talk to them and find out why they stay on. And this is a very small group of doctors actually who actually continue to serve for long periods of time in really remote conflict-affected areas in India. This bridge was destroyed by insurgents. The land on the other side is insurgent territory, not run by the army at all. It's run by insurgents. This is civil conflict in that area, in a state in eastern India. And we found these reasons. And again, not rocket science, but we did the research, very cheap research to do. We just went and spoke to them, spoke about their experiences, and elicited these findings. That there are actually very strong social affinities that get doctors to stay on in those areas. So it's a very strong argument actually for affirmative action. Of a particular type, that you need people from particular communities because they are more likely to go and serve that particular community because they have social affinities there. So altruism is probably a misused word, but certainly personal values of services also were didn't just come out as opinions, but did come out in different ways through the experiential narratives of the subjects of that research. But there were a different set of reasons for why they stayed on, right? And this came out as the biggest factor. Strong relationships with colleagues. Also, there were a lot of doctors were kept hanging on, saying we'll promote you, or we'll get you regular jobs, but they didn't. So these all have specific indicators for policy, and this work fed directly into the state's health policy. They created, a cadre of rural practitioners who were better paid, and they had a policy. They changed their posting and transfer policy to ensure that spouses could stay together in the same locations in rural areas. They did a number of other, what I would call micro and meso level innovations that arose from this work. So that was kind of a summary of all of the work on the mixed health systems. And then the next part is really going to talk a little bit about the governance and some of the governance challenges that arose as a result of these configurations and how we address them. So why governance? And I asked myself that question a lot. Again, in retrospect, why did we focus on governance? Why did we all agree? Many of us, there were we were a group of about 30 people and researchers from different parts of the country and from across the world who were focusing on governance issues. And I tried to sort of deconstruct it and think why we all thought governance was such an important issue. And I think it really came from these three types of concerns. And the first is we all had some experience of working in the health system and the health sector. Not necessarily as researchers, either as planners, providers, practitioners in some way. I think we all sort of knew internally that it's the governance challenges. Things did not happen the way they should happen or the way they're supposed to happen. And a lot of that was due to decisions taken by people in positions of authority at different levels. And then I think it was also coupled with a pretty fundamental social concern, which I think, and this again speaks to the importance of working with researchers who actually work in a context. It's not just that we need to create, suppose we are here in the UK and we need to do work in another country, less affluent country. It's important to create the partnerships, not just because we want to check off that we won't need to do equitable partnerships or be respectful and all of that. Yes, we do need to think about all of that. But these people actually are part of that society and they're invested in that society, right? So they have a much more skin in the game than we have, sitting out here I was in Geneva and now I'm in London. But that wasn't always the case, and I think all of us who made this group were really keen on this idea of better governance. So it's a social value in itself, which goes beyond just providing health care. And so that's why I'm not a big fan of people who come in and do RCTs on different governance mechanisms, because this is something that we need to develop our society. It's not an either-or situation. So, but anyway, that's just that's the only bad thing I'm going to say about RCTs today. So, but I think it is an important one. And then that kind of led itself to this sort of more academic pursuit, which I think I can summarize in this rather heavy definition, confronting the living constitution with the manifestations of the written. So comparing what is supposed to happen with comparing what actually happens in terms of how institutions of governance perform their actions. A couple of definitions here, I won't bore you with those, but I think this again reflects that. Sridhar, I know you'll like this. Amartya Sen's book from the Idea of Justice, 2009. So again, kind of linking into the sort of ethical foundations of some of what we did and why we did it. And he said that, look, we know there are all these rules. We're full of rules. Our societies are full of all kinds of procedures, norms, bureaucracy. But we need to understand what actually happens inside of these systems. We need to focus our understanding of whether people are being served, whether systems are being served as they should, by actually exploring that reality rather than by saying this is what should happen and basing everything off that. And so we launched work on 3 broad areas, which I will generally, which I've classified as regulatory systems, community systems, and ministries. These were the 3 broad types of institutions that we did research on, governance research on. And again, what we did, a lot of what we did was this, just walking up to those people who worked in those institutions and asking them, I mean, not so obviously, I mean, we conducted in-depth interviews with them, with all the kind of checks and balances of research that could get us published, and we did robust research. But it was really, in effect, what it was interviewing people, talking to people about their experiences within these institutions. Right? So if you work with a healthcare regulator, or if you work with a regulator of medicines, what is it like? What are the kinds of pressures, pulls and pushes you face? What is your experience of enforcing your functions like? And then this other very interesting theme we pursued with actually a global consortium working on issues around posting and transfer. And I don't know if Talib, we were ever discussed that at some point. I'm sure we've spoken about that and worked on that at some point in time. So we found, so with regulatory systems, there are several reasons and explanations for why they don't function as they should. Some of them, many of them relate to capacity, and I'll come to capacity separately. Design gaps, lack of functional clarity, but then also very specific political and power-related themes, and those are like the impact of professional interests primarily, specifically medical professional interests, and their influence on the design and the implementation of regulations to make it more conducive to their service of their markets and protection of their markets. I would go into an example, but I don't think I have enough time, but we can always discuss that over drinks. And then with posting and transfer, the existence of informal parallel arrangements for health worker deployment. So a lot of the policies actually get enacted through informal arrangements rather than, and which are sort of work side by side with the formal arrangement. And there's a sort of a status quo. So people would set up their preferable postings and transfers, and there was money exchange, but that wasn't the only thing. It wasn't just corruption. There's something more complex to parallel systems than corruption. So these are the themes that started coming up from this work on regulatory systems. And so that was a lot of our work on regulatory systems really threw up what was wrong with the system. But we also did a lot of work on what could go right in systems and in governance. And the work on community systems was a large part of that. With WHO and IDRC, we worked on strengthening village health committees in India. So health committees, there are 350,000 health committees in India. So it's a really universal phenomenon across the country. There are many similar analogous entities in different countries. And so what they do is they get communities involved in health planning and to have a voice, to have a say in how plans should be developed in their particular village. And this happens because India has a system of decentralized local governance, self-governance, and they have a law for local self-governance. So you are able to set up the systems. And we actually found that the existence of the law was very significant in being able to sustain and actually help these institutions to survive. So they were quite vulnerable to capture by elites, but at the same time, they also did, in different ways, amplify citizens' voices. They managed to change the way that plans were made. They managed to include more voices onto health planning. And we also found that there were a set of these kind of, again, coming back to this theme of boundary spanning and hybrid organizations. There were some organizations that were uniquely placed to be interlocutors between communities and authorities, and those entities actually were more effective than when the government tried to do that job themselves of engaging communities. So that was still work I did in India, but then I did this work with WHO, specifically the governance and financing team on ministries of health. So governance capacities of ministries of health. And we did a range of studies in different countries and came out with a report, which I'm sort of capturing in 2 sentences here, but really it says that many ministries struggle to balance cross-cutting organizational capacities and technical depth. But at the same time, the big theme for ministries was that there was a huge expectation of them to undertake a whole range of functions for which they were not ready. And those were largely soft capacities like change management, relationship management, especially with the private sector, and leadership in terms of advocating and propagating specific values. Again, happy to discuss this in more depth. I don't have time to go into some of the details, but it'll come back when we talk about some of the broader themes. I'll try and pull some of these themes together in this slide. I think it's this slide, yes. So what all of that does is, what all of that research on governance told us and helped us to realize is that when we talk about wicked problems and we talk about insurmountable health systems challenges, the research on governance actually did help us to unpack some of the explanations for these wicked challenges, and also to some extent point towards the ways of resolving them. For example, I'm just taking these 3 examples. They're big examples, but they don't encapsulate the sum total of what should happen in health systems, but they're still quite significant in themselves. Suppose we say that we know that primary care is generally underserved in many low and middle income countries. It's underfinanced, it's underprovided. We know that access to healthcare is inequitable to a large extent, and we know that there's a significant problem of healthcare quality. So we can attribute all of these to a proximate explanation, which is that we don't have enough skilled health workers. The people who are not skilled enough are not that effective for various reasons. They're not trained, they don't have the career pathways, so forth. And we know that our effective regulatory systems are not that effective, right? But then what we do is we also identify the underlying challenge behind that, which are really governance challenges, or what I would call governance challenges. There are some of the diagnoses that we came up with in our work. And these are what I would call meso-level themes that I think need to be understood and developed more strongly. The capacity gaps, the organizational capacity gaps, the sort of mid-level politics that plays out when you see a doctor heading a nursing council, and when you see medical professional interests imposing themselves into regulatory policies that should be for all healthcare providers and not just for doctors, and ultimately for the people whom they serve. Institutional capture of different forms. I know Dina has work on corruption, which I admire greatly. And I know that I want to have this conversation with her about institutional capture and say that, is this corruption, and how can we maybe unpack this differently? There are elements of corruption in there, and there are parts of it which are not corruption. There's something else, and it's important to understand that better. And then I think really crucial to identify this, and why this is important. It's important for various actual reasons. There is a huge lack of learning in health systems, and that was the reason why we wrote a whole report on learning health systems. But it's also important for this lecture because I think it gives us a little better sense, at least it gave me a better sense of what we need to be contributing as institutions of learning, and how do we play a role in all of this. And this is the part where we should be contributing in the learning gaps, and in terms of what we actually do as our professions, and what role we play as academics, as researchers in health systems. And then of course that then highlights what are the potential avenues, arenas for action. And again, this is not something new that I'm saying. We do need to develop institutional capacities in specific ways. The constitutions, the values, and the policies are really important. The laws are really important, and community power and learning systems. So again, this just sort of tries to encapsulate what some of the research does in terms of its contribution towards our understanding of how seemingly intractable health systems problems have understandable and researchable causes, and potentially solutions that can actually be addressed. Now what's remarkable about these solutions is that very few of them can actually be undertaken from outside the system. Right, so I used to be at WHO. We all thought we could change the health systems in other countries. We have a very peripheral role, as anybody sitting outside the system. These are all things that happen from within. And I think that's another realization that But it doesn't mean we are powerless. It does mean that we can do a lot. I mean, and especially in this arena. But it helps us to think about our role a little bit more. And that, again, then takes us to this part of the presentation. How are we doing for time? Okay, maybe I'll go for another 10 minutes. Which is on the work I did on this part, the making the significance of research and making research more significant, making it more impactful. And again, this is really has been a collective journey in many more ways than the research has, because it's been all about coming together with different groups, building institutions. This is some of the work we did in India. The National Knowledge Platform was the first ever domestic financing mechanisms for health systems research in India. And we worked with the Ministry of Health, specifically the late Keshav Desiraju, who was an amazing health systems builder and pioneer, who recently passed away, and who had the vision to actually build the system. And so the principle behind this was that we need to be supporting research on health system challenges. And in India, so this was an Indian context, but currently the mechanism to support research is through the Medical Research Council. And so what he did is, yes, we need to have research of that sort, which is supported by the research councils, but we as the Ministry of Health also need to support research, which is much more of the applied nature. And so he set up a financing mechanism from within the Ministry of Health. And that supported and complemented the work of the Medical Research Council. There's the Indian Council of Medical Research. And they both groups got involved and made it a reasonably effective platform for some time. It had its period when it wasn't so effective, but it certainly created a precedent. The other piece of work we did with 13 other research organizations in India altogether, some familiar faces there, whom you might recognize as Cara Hansen, Barbara McPake, who are on our advisory board, Helen Schneider, Richard Cash, and a number of Indian professors, Sundari Ravindran, John is here, John Porter, and members of our Health Governance Hub. Thelma Narayan from Sochara. So all of us got together and said we need to strengthen health systems research capacity in India, and we set up a collaborative called the Keystone Initiative. First national postgraduate fellowships in health policy and systems research. And if you go to YouTube, you'll still find our videos up there. It was done quite a long time ago, but I think some people are still using them. And I have to credit this process, which was the real inspiration behind that. Behind all of the movement that's happened in health systems research for the last 12 or 15 years, almost all of it has its provenance in this amazing effort, which was led by the Public Health Foundation of India, specifically Srinath Reddy, the president of the Public Health Foundation of India, who were commissioned by the government to set up an executive group on universal health coverage. And they developed some of the most visionary and complex policies, complex in a good way, because they really captured the breadth and depth of the complexity of the Indian health system. And I think that led a whole generation of us to try and start to explore some of the complexities of the system and address them through better research. And unfortunately, this was taken up. The recommendations of the commission were taken up, but after 2 years, the government changed. So, and a lot of them were put to rest, but still it has had a significant impact on health policy in India. And then, as I said, another big area was the sort of community and again, that's all of us sitting here, and Tolib is now the chair-elect of Health Systems Global. So the torch has gone on in very fine fashion. This was the coming together of this movement of people working on health systems and health systems research, the Health Systems Global Society, which if you're interested and you're a student, please do join. Putting in a little pitch there for Health Systems Global. And I think what was unique about Health Systems Global was that it was a Global South-driven initiative. Equally, I'd say there was a true partnership, a North-South partnership, with a lot of really strong Southern leaders who came up. And a lot of the important discussions around inclusivity that have become sort of mainstream now were actually had by Health Systems Global well before time. Isn't it, Dina? I'm sure that you remember some of those conversations. And I don't know if you remember this big alarm that happened when the issue of visas, for example, for conferences was really a big issue for us at Health Systems Global, because we wanted at least half of our participants to be from the Global South. And many of them didn't get visas. It became a big issue, and The Guardian reported on it in the Liverpool conference in 2016. We wrote about it, and we confronted it and brought it up. And I think Health Systems Global is continuing to confront this issue and bring up this issue of equal participation in global health debates and global health discourse across countries, across the Global South. These are some of the themes, these are some of the activities that happened at the time I was there. We started a media fellowships, which involved journalists, and we started engaging policymakers much more. And the youth group, the Emerging Voices, was inducted into Health Systems Global. So this was kind of more like the community side of the work on health systems. And then in 2018, I joined WHO. And there, I think the real big learning from the WHO experience was on working much more closely with the users of research. And that's what WHO still does, or has a very effective platform for, I think. I'm not sure if it's always used as effectively as it could be. But they have access to like every Ministry of Health in the world, right? And but alongside that, the credibility of the UN organizations carries a lot of weight in some circles, maybe not in other circles today. But there was access, we had access to policymakers, which again, I don't think is something unique to WHO. I think this is something that anybody in research could be doing more. And I know it's one more thing that we're adding, yeah? I mean, we have to do everything in the kitchen sink as academics. But I think as one progresses in one's career, I think it becomes easier and easier to start engaging and discourse with policymakers much more. And again, that was, I think, one of the key lessons from that experience. A lot of work here on digital health systems, primary healthcare, with MRC, with the Department of Health, with the Gates Foundation, but also separately. And I suppose the main focus, again, as I said, was on centering policymaker perspectives and saying that, look, we need to start collaborating with policymakers, but that is the first step towards then embedding research into health systems and ultimately institutionalizing research within health systems. And that's the direction that some of those conversations took. Again, a kind of persisting impact of the primary healthcare agenda sort of really underpinned all of that, the values of primary healthcare. Astana framework came up while I was there, and that became a key guiding framework. And then drawing from that kind of institutionalization idea, this concept of learning health systems. Sorry, this is the last heavy idea I'm going to present. I know it's a long presentation already. But I'm going to say a little bit about it because I think it's significant for some of the next few slides, and then I'll try and close. So learning health systems, really, there were 2 or 3 different things we try to emphasize here. The first was on differentiating the different types of learning that occur within health systems. And maybe I'll draw the first thing on the loops, right? So a lot of the type of learning that we engage in as academics, say, in health systems, we were researching health systems, or say the big global health initiatives, when they say learning, many of them think about learning as single loop learning, which is basically about making adjustments to what's happening, to course correct. And this leads to more informed and better practices, certainly, and to an improvement of performance of functions. But what it doesn't do is it doesn't challenge some of the underlying assumptions that exist in policies, in health systems, in programs. It doesn't go underneath, it doesn't acknowledge failure adequately. And as a result, it doesn't necessarily promote genuine adaptation and genuine change within health systems. And then the third type of loop is what we call triple loop, which is also referred to as learning how to learn. So that's more about setting up learning institutions and setting up the systems that will help us to do the single loop and double loop learning better, right? And with the setting up of learning institutions comes not just improved performance and increased adaptivity, but also increased ability for learning. So what you're doing when you undertake the more deeper types of learning, the double loops and the triple loops, is you're not just improving the health system. You're not just improving the performance of the health system. You're actually strengthening the health system. So when you leave it stronger because you created capacities within the health system to learn for itself. Right? And this is a dialogue I had with some global health funders because they have these masses of money that they want to invest in health system strengthening in countries. And so as a result, they want to know what their returns on investment are. This is the commonest question. So they come to health systems experts, right? And Sophie Witter has done some fantastic work in this area. She's not in the room, but she really needs to be acknowledged for her work in this area. So unpacking what is the difference then between just trying to create improvements versus actually trying to strengthen health systems. And I think the learning part is a big part of this health system strengthening effort. And this has, why I went into a little more detail on that is because this has some very specific significance for us, the people sitting in this room, us in global research institutions, global learning institutions, in many ways. So it helps us to think about, we could ask ourselves some questions around scope. So learning doesn't just happen through the transfer of evidence or the transfer of information, it also happens through deliberative practices. So are we doing more or enough of that convening, bringing people together, talking about issues? Deliberative practices are create more learning than the sum of the parts, right? It's the deliberation itself creates additional learning. And then an incredible amount of learning happens tacitly through action and practice. And we don't really capture that, or we don't have mechanisms to capture this in our universities. And then again, have we really engaged in double loop learning? Have we engaged the decision makers impacted by our research, and to what extent have we engaged them? Are we working with researchers close to context? Are we creating space and incentives for people with these types of experiences, the deliberative and action research type or action learning type experiences? Or are we only focused on people who will produce a lot of great publications? Nothing against publications, but we do need other types of incentives. And a lot of the new frameworks for research assessment in the UK and in Europe actually are very progressive on some of these themes. I think it's us academics who need to catch up with some of the very progressive steps that they have taken. And in terms of really expanding the scope of action for academics. And then thinking about impact. And this is, of course, a big one because everybody wants to know what is impact. And I genuinely think that we need to find better ways of understanding how learning has occurred in health systems as a result of our interventions as academics in health systems. And then the triple loop has local capacity to learn increased. Okay, last two slides, and then we can stop. And I'm going to try and keep it brief, but this is really about the kind of future thinking and trying to capture some of what I've said before, but really then moving on to the next step and thinking about what the future holds for us, the changing health systems. Mike, I know we're going to be working on this soon. Mike leads our work on changing health systems at UCL. So I'm sure some of this will not be new to him. So this is what I call the attention horizon. This is what's above our attention horizon. We hear about climate change, we hear about pandemics, we hear about conflict, we hear about applications of digital technology, and this is all very scary and all very current and all very present, and it needs to be addressed. Right? But this is capturing a lot of our attention when we think about health systems or when we think about anything in the world. It's in the newspapers, it's in the headlines. But there are other big things, big changes happening in health systems right now as we speak, which are not capturing so much attention. Maybe they are for academics, but not so much, not more broadly, and not so much for policymakers as well. For sort of global health folks as well. Africa is going to have more megacities than Asia in 40 years. That's staggering. We don't know the scale, we don't realize the scale of urbanization that's taking place. And it's happening much in ways that are not really properly understood. And why that's significant is because most health systems have been cast in a rural health mold. So we haven't got the right design for urban health systems. And with that, urbanization has come, and not just with the urbanization, but independent of the urbanization has come massive changes in configuration of private markets, both through the existence of new markets and new technologies, but also through market consolidation that's happening with really big players entering into the healthcare space who were previously not in the healthcare space. And we need to understand this much better. And then, of course, the spread of what WHO calls the infodemic, the massive spread of disinformation, which is happening on health, which is happening not just inadvertently, but it's happening in very organized and specific ways. So there is some recognition of these things, but they do need more attention. And below that, and what receives much less attention, is that some of the old problems still persist, right? All the old problems, almost all of them, still persist. And those are the governance challenges, the market failures, the conflicts and contestations between all these different constituencies, the persistent inequalities, fragility, and vulnerabilities, right? And these are things we can predict, we know. They are already upon us. These are less predictable. So the point here is not to say that any of this is more important than the other. It's that we need to address these in conjunction with each other. We need to look at surface phenomena in conjunction with the underlying social phenomena that are driving these changes in health systems. And for that, we need to really use social science methodologies to their full and maximum impact. And currently, I don't think we are. I think we're touching our feet in the water of health systems. And there's a lot of health systems challenges out there which social scientists could be engaging more strongly in. So the future agenda does include all of those issues I spoke about: mixed health systems, urbanization, migration, digital interventions, epidemics. But at the same time, it also must continue to address the unfinished agendas of universal health coverage and primary health care. And in terms of how we address these challenges, we need to use the full breadth and power of social sciences more effectively. I would suggest we should now turn to prioritizing some of the meso-level questions so that we can start building the patterns and typologies of what happens, what goes wrong and what goes right in health systems. Learn across contexts and really build out that science. What are these key things? I just highlighted two of them: institutional capture and professional dominance. But there are many more that we could go into, like corruption, like maybe there are other themes that we can pick up and we can talk about, and build out that science. We need to support and collaborate with decision makers in policymakers and in policy and community much better. And we need to do much more to facilitate learning across contexts. And I'm going to close now with thanks to these fantastic people who've all been part of this journey, some of whom are in the room right now. Not going to list all of them. I've referred to many of them along the way, but yeah. I just want to highlight these people: Veena, Shay, Devaki, Prashant, Steph, and at least 30 more people I could list who are really on the forefront of taking forward this field. Julie is here. Thank you, Julie. And so we really need to support health systems research more and do more to take this community and this field forward. And I would be remiss not to say how much I appreciate the welcome I've received over these last few months, and what a fantastic environment UCL has been to take forward this agenda. And last but not least, my family. Thank you.
So thank you so much, Kabir. And it's really been a pleasure listening. Kabir and I decided, well, rather than having questions, we would move to the drink reception and there have lots of questions. So please just go outside and our team from the Global Business School for Health will direct you where to go. Thank you so much.